Well, thanks, Eve, for inviting me, and thank the panel for, or the forum for having me here today. And as Eve said, I've been working with David Hawkins for the past 35 years in developing our research group, the Social Development Research Group, that's now led by others. We're so happy to have created something that we've been able to pass on. So for over 35 years, we've been trying to understand the predictors of both positive development and the predictors of problems that get in the way of healthy development. In addition, we've then used that information to develop and test a variety of prevention and promotion programs, including school-based family programs as well as community programs. And in addition, we've developed and tested tools to build the capacity of states and communities and schools to build prevention infrastructure to plan and implement appropriate evidence-based prevention and promotion. And it's my view that I share with several of the presenters over the last 2 days that building prevention infrastructure is necessary in combination with the right measures to produce broad-based prevention fidelity and sustainability and impact of evidence-based programs. So I'm going to start out with 4 points that I probably could just end with, but I'm going to continue on in this vein. But the first 4 points, first raised by Bob Gorgie yesterday, is that, and emphasized by many people today, is we have the measures. I'll be adding to them today, but as a field, we have the measures. That's not really what we need to do. We've got them from administrative sources, youth surveys, providers, and citizen-collected data. We have them, and of course we can always improve them. As Rachel said, though, and others said today, we know how to improve them as well. So I think we're in a place that we absolutely need to move forward, and although we have these challenges, we have them and we can move ahead. The second piece is that I think, as Jeff Schiff said yesterday for the first time, but again echoed by Harold and Sarah at the earlier presentation, the measures must make sense to families, youth, and frontline workers. And when you've got the measures making sense to those people, you have incredibly strong advocates for evidence-based programming, fidelity, and moving that ahead. And the things that I'd like to kind of add is that we have to build both commitment and capacity to support evidence-based programs and measurement systems. You have to build the capacity. Several people have talked about that, but you also have to have the commitment because building that prevention infrastructure with capacity and commitment creates citizen advocates for prevention. And these citizens are probably your best, are in the best position to support evidence-based practices in their communities, the best choices for their children and families, and they'll be the best advocates for taking evidence-based prevention to scale. So I have 3 objectives. How can communities incorporate research base for prevention science into local prevention programming? How can communities build prevention infrastructure to ensure implementation fidelity? And then I'm going to use communities that care as a kind of an illustrative case and talk to you about how it achieves fidelity of implementation, choice of evidence-based, appropriate evidence-based programs, and how it implements them at scale with fidelity. So we have a burgeoning knowledge base for prevention science summarized in the National Academies volume on preventing mental, emotional, and behavioral disorders. Actually, in that book, they summarize three things. We have a strong epidemiology and etiology of problem behaviors. We know about risk and protective factors. As a result of knowing what those are, people have designed interventions to reduce risk, enhance protection. We now have a variety of evidence-based prevention programs also summarized in that book across multiple disorders. We also have prevention services research, which uses this information from the first two to how to build effective prevention infrastructure so that you can use community science to achieve community impact. It would only be so easy. Despite all this progress, prevention approaches that haven't worked, that do not work or haven't been evaluated, are much more widely used. Several authors have shown us this. The challenge for the 21st century, if you will, is how can we build a prevention infrastructure to increase the use of tested and effective prevention policies and programs with fidelity and impact at scale, but recognizing at the same time that communities are different from one another and need to decide locally what policies and programs they use. So building prevention infrastructure, really again, I'm going to have these two ideas of capacity and commitment throughout here. You really need to build the capacity of local coalitions to reduce common risk factors for multiple negative outcomes. If we don't build the capacity, we can't get the measurement tools utilized in the correct way on the ground. What does that capacity consist of? Assessing and prioritizing epidemiological levels of risk, protection, and problems. Choosing programs that match local priorities, getting citizens involved in these local coalitions, and implementing chosen programs with fidelity to those targeted. Now, we have to build these capacities in each of these areas, otherwise we're not going to get people choosing the right programs, we're not going to get them implementing them well, and we probably won't have enough saturation to get impact. I'm going to be using throughout my talk Communities That Care as an example of doing this. I'm doing that because it is an effective, tested and effective system. It's a proven member to build both commitment and capacity to prevent underage drinking, tobacco use, delinquent behavior, including violence. This idea, again, was developed in 1988. It doesn't happen overnight that you can, design something like this. It had 15 years of implementation and improvement through community input prior to our use in a randomized trial. So all that work people have been talking about, getting community input and making sure that you have all the right elements in it. We've been forced to do a lot of things that we didn't think were necessary, but communities told us, yes, indeed, they were necessary. It was good to have, and I'll describe some of those ideas. But it's been tested in a randomized trial that I'll describe just a tiny bit. Across 7 states, 24 communities, 12 assigned to experimental and 12 assigned to the control condition. And the CTC effects have been independently replicated in a statewide test in Pennsylvania. So David Hawkins was the PI of this grant, and there's 24 incorporated towns that were matched within state, randomly assigned to either getting the CTC intervention or the control condition, 5-year implementation phase, and a 3-year follow-up post-intervention that continues to go on. And we have a longitudinal panel to test the effects of this. They were about 4,400 kids that were surveyed annually starting in 5th grade. We followed them wherever they go. Our newest follow-up rate is? Yay, this is at age 21. So I'm not going to give you results all the way through 21. We've just finished data collection, 90%. So these are all the kids, no matter where they go. I'd like to just nod to the National Institute of Drug Abuse and the Center for Substance Abuse Prevention. Is there anyone else? Is NCI in the room? I can't remember. You can see all the funders. NIMH is in the room too. So we have, it takes a village to raise a randomized trial, and so we have many NIH institutes thought that this would be a great idea. NIDA provided the bulk of the funding. It's in bold, but many other institutes collaborated. And we had state collaborators at the state office level in alcohol and substance abuse, and many of these are now alcohol, substance abuse, and mental health divisions these days. And I'm just showing you this. I've given you as the panel or as the fora, I've given you the papers on this. But I just want to say, when you do this, I'm not really trying to highlight the results here, but I just to show proof of concept, that after 3 years of implementation, we get outcomes in delinquency initiation and targeted risk. Over time, that's after 3 years of, I'll show you the timeline in a second, but that's after 3 years of implementing CTC, 2 years after putting evidence-based programs in place. Those effects expanded to include substance use and increased protection at 4 years. At 1 year post funding for all the evidence-based programs, those results many of those results were maintained, and maintained 3 years after for initiation. So how does that happen? We build these citizen coalitions of diverse stakeholders, and I call them citizen coalitions. You know, we also get key leaders, elected officials, and judges, and faith leaders, and business leaders to kind of bless the process. Yes, indeed, we want to move forward. But then we get citizen coalitions that include moms and dads, that include people at different not-for-profit organizations like YMCAs. We get folks that are involved in schools and churches to sit on a coalition, and we build Communities That Care helps build the capacity to develop the capacity to build these coalitions. They assess, prioritize risk protection and behavior problems with the student survey. They address locally prioritized risks with tested effective prevention programs that are matched to those priorities. And they support and sustain high fidelity implementation of these chosen programs. How does that happen? We build those capacities by getting commitment from key leaders and community members, funding a community coordinator. You'll see several things in yellow here on this. These are the measurement instruments that I'll be discussing for the rest of my talk. Training in the strategy, monitoring the Communities That Care implementation itself and its implementation fidelity, technical assistance, assessment survey every 2 years so they can look at levels of risk protection and outcomes, funding of the programs, training in the programs, and then fidelity and reach monitoring of selected programs. Lots of training, about 9 days of training in 6 to 9 months. Here's the timeline for that. The training that I've just mentioned here gets you to the end of developing a strategic plan, and then at 1 year, that strategic plan is implemented, using and implementing the tested and effective programs that the risk assessment suggested that people get put in place, and then evaluate 2 to 5 years. We expect to see outcomes in risk and protection. And outcomes in 3 to 10 years. So the implementation fidelity of CTC is measured by milestones and benchmarks. They're the steps, actions, or goals needed to make to do CTC in the way that it's intended. So we do a lot of capacity building, again, for this, listed in the manuals and discussed in workshops. You can see that it's incorporated into the coordinator's performance objectives, it's reviewed by technical assistance providers, and it's assessed by both the community coordinator, our TA staff, and the CTC trainer. These are the kinds of things that it is. The milestone is the bigger goal. The benchmarks are the steps to get to that goal. Here's a couple of different benchmarks for Phase 5. Implementers have received the needed training and technical assistance in order to put the programs in place with fidelity. And you can see that over the years, the first 5 years of implementing CTC, we had fairly high levels of fidelity for the CTC process itself, 89 to 100% in year 1.5, and even by the 5th year, 83 to 91% were meeting the milestones and benchmarks for each of the 5 phases. The second piece of measurement is the Communities That Care Youth Survey. It assesses young people's experiences and perspectives. 6th, 8th, 10th, and 12th grade students take this. It's reliable and valid, and again, this has been developed over about 25 years, so we have it's not static, as Rachel was saying, but it does have reliability and validity across many different groups, states, genders, ages, and racial and ethnic groups. That work continues. It identifies risk and protective factors and provides a foundation for selecting programs. So for instance, here is a risk profile of one community, and why do we say assess local risk? Well, in this case, this community has family management and parental attitudes favorable to use as being elevated, this is favorable attitudes towards drug use and friends' use of drugs. These risk factors. We developed a technology to display them all on a single scale. Here's a different community having different things that are priorities, like community disorganization, academic failure, and interaction with antisocial peers. So different communities have different risks that are elevated, just like if you have a cold, a certain kind of treatment might be indicated. If you have the flu, a different type would be indicated, and the same for communities. As you can see then, communities do choose a variety of risk factors. 5 to 9 people in the yellow here have chosen the similar risk factors, or not people, but communities. These are communities across the top, but there's many communities that are not just picking those and picking others. So you can see the risk assessment is actually driving them to pick different priorities. That leads to different programs. That's a great thing. There's school-based programs and after-school and parent training programs, but it creates a challenge for those of us in the measurement field because we have to measure fidelity across a range of programs and encourage local ownership of these different programs. We measured adherence, delivery of sessions, including the number, length, and frequency, the quality and participant responsiveness. We got the program implementers and the community board members to do this. So again, citizen advocates, citizen implementers, which really builds commitment to them. We had to develop 7 for the 16 programs that we had, provided similar information. The checklists were really completed, as I just said, by coalition members and program staff, and we provided feedback that was timely, as many people are saying here also. Local community, how did we build capacity to do that? We had part of it was in a training, part of it was making sure that the coalitions routinely tracked this implementation and not only tracked it, but they were the ones who funded this program, who pushed the program forward, and so they said, you're not doing it right. You're not doing those life skills training every week. You're doing that. You're taking 2 or 3 weeks to get back to the next lesson. That's not right. You're not greeting, if you were doing guiding good choices, you're not greeting the parents at the door with a smile. You're all talking to yourselves. That's not how we do guiding good choices here. So we also had external monitoring and technical assistance. So there you have it. Here's our community board member. He's watching what happens in a particular school-based program. We had fairly high levels of implementation adherence and participant responsiveness. I have two other measures that look very similar, fairly high ratings across these scales. And so I'm ending with just building prevention infrastructure, capacity and commitment are both needed to sustain effective prevention impact with fidelity and impact at scale. We have to build capacities and provide tools. That's our jobs as scientists. But these are not organized systems. These are not organized providers. And we've been able to get them to choose the right programs for their community, implement different kinds of programs with fidelity and care about that fidelity, and achieve outcomes and get enough saturation to achieve outcomes. So really, my last point is creating citizen advocate scientists is the way to build advocacy for evidence-based prevention at the local level. I think that also helps in the state of Pennsylvania, where they're doing it in most counties in Pennsylvania. It's been able to be implemented since 1994 or 5 until today through about 4, 5 different governors across administrations as a result, because now you have 60 teams or so that are active. There were about 100 at the peak, but there's 60 teams that are active advocating for science-based prevention in Pennsylvania. So it's possible. Thank you very much. I know I've outlived my time clock.